the Public Health Service, and we came first. So it's the Public Health Service. Our presentation today will highlight the journey of health equity, or to health equity and wellness for American Indians and Alaska Natives. And we've been working on this for a few years. I'm Susan Carol, and I'm also the CMO for the CMS Division of Tribal Affairs, and I was the former CMO for the Indian Health Service. With me today is Carrie Field. She's a senior policy analyst from the National Indian Health Board, and Karen Matsuoka, who is the senior policy advisor for health equity to the CMCS, Centers for Medicaid and CHIP Services Director, Dr. Dan Tsai. We were going to have Jim Roberts, who's a policy advisor for intergovernmental affairs for the Alaska Native Tribal Health Consortium, but he couldn't make today's event. I want to start with some of the slides, or I want to start with some of the topics that he was going to bring to our presentation today. And basically, I don't know how much all of you appreciate or understand American Indian Alaska Native history, but way back in 2028, there was this thing called the Merriam Report. And then fast forward to 2004 and 2008, actually 2018, was the Broken Promises Report. These reports were very instrumental in demonstrating a common thread of problems with American Indian Alaska Native healthcare. The biggest thing is that healthcare for American Indians really lacks adequate appropriations. And depending on who you listen to nowadays, it's somewhere in the $22 billion range for what they would need to get them to the point where they can function in what we would consider a regular non-American Indian healthcare facility. So appropriations. And we continue to fight with that this day. Those reports also brought up boarding school issues. The big problem was staffing shortfalls. We are located in the most rural frontier settings across our country, and trying to find enough nurses, enough therapists, every aspect of healthcare is a real challenge in American Indian Alaska Native facilities. The infrastructure of the facilities also a huge problem across the country, with most of them being built roughly in the 1950s, with very little upgrading and very, very little present day building. The facilities list is 20 years long. So if you are lucky enough to be on the list, 20 years from now, you might get something new. And so that has caused tribes to have to just put forth their own funding, their own money, their own land to try to upgrade what they have. And they've been successful to some extent. There's beautiful places out there, but there are some very basic facilities out there too. And the last thing that the reports mentioned were dental needs. I'm the one that's supposed to be pushing the slides forward. Don't forget. So that's who's here. So the CMS strategic plan is something that we've been working on for about 3 years now. The biggest pillar, the first pillar, is on health equity, and that's why we are here today. That's why across CMS we strive for health equity in just about everything we're working on. We have a strategy to advance health equity. It's listed on this slide. I think that we all get a copy of these slides at the end, and that link will bring you to that pillar. Slide 4 is on the actual health equity framework. There are 4 specific goals that guide Medicaid and CHIP work in closing the gap, in outreach efforts, expanding and standardizing the collection and use of data, which is so critical for American Indians and Alaska Natives and has been lacking from past work going back just a couple of years, actually. And also ensuring engagement with and accountability to the communities that CMS serves. There are 6 other health equity priorities, and the 2 most applicable to us are expanding collection and data and an analysis of the data. And number 5 is increasing all forms of accessibility to the healthcare and to coverage. Over the last 2-3 years, we've been working very hard at trying to understand what health equity means to American Indians and Alaska Natives. You might think that might be an easy thing, but really, in actuality, it has not. We have had at least 2, if not more, listening sessions with the American Indian Alaska Native population, and then in collaboration with the National Indian Health Board, we held a health equity summit 2022, something like that. And we've been gathering this information, trying to get an understanding of what health equity means to us. We've broken it down basically into 3 domains. And in doing that, the first thing that we did was put together a report. I want to thank Carrie for that great work. The National Indian Health Board put together a fabulous report. It's linked in the next slide, I think, or this slide. No, this slide, to look at. And ultimately, it shows 60 plus recommendations for the government agencies to look at to understand Native American healthcare and the issues that we feel we need to correct. And it's a great report. If you have some time, download it and take the time to go through it. So our first domain that we have been working on is called the TTAG priorities, TTAG administrative priorities. TTAG is the CMS Tribal Technical Advisory Group. There's about 17 individuals on that advisory group coming from each of the different IHS areas, along with the National Indian Health Board representative, the National Council of American Indians, NCUI, National Council of Urban Indian Health, and the Indian Health Service. So that Tribal Technical Advisory Group looks very critically at issues that come up for American Indians across CMS, and we've identified through our subcommittee work and even more refined a work group that has been set up to identify which of those priorities are most important to us. And we identified reimbursement of tribal freestanding clinics at the Medicaid outpatient all-inclusive rate. I don't have time to talk about what that means, but to TTAG, the all-inclusive rate is extremely important, and we're working towards that. The second one is requiring Medicaid Advantage plans to reimburse the Indian Health Service, tribal, and urban Indian organizations for services provided to American Indians and Alaska Natives enrolled in CMS plans. The third priority is providing guidance specific to American Indians and Alaska Natives' use of Medicare Advantage plans. And the fourth one is approving 1115 demonstrations that cover services important to tribal communities. And right now, one of those demonstrations has to do with traditional healing. Our second domain that we chose to look at is the health equity report. And we picked 3 items: internal CMS training to make sure that our agency knows what American Indians and Alaska Natives need, and then CMS compliance with tribal consultation, and then to improve American Indian, Alaska Native data collection and reporting, as was already identified in our health equity framework. And Carrie will go into more detail here. The third domain that we're working on is behavioral health and the overall sense of well-being, diabetes management, and maternal and child health. We have about 7 different metrics, and you've heard a lot about maternal health, and our TTAG also have important requests for maternal child health. And finally, access to care, which we talked about earlier. This is my contact information if anybody needs any further information or has any questions. but I'm always more than happy to chat and talk with you about American Indian Alaska Native healthcare. I will turn it over now to Carrie.
Oh, yeah.
Thanks, Dr. Carol.
Yep.
So I'm Carrie Field. I'm a senior policy analyst with the National Indian Health Board. I'm on our federal relations team. And I think one of the common themes that's come out kind of over the past couple of days of this health equity conference is the importance of perspective, and kind of how we're approaching different issues, how we're thinking about them, and trying to kind of expand a perspective and to kind of understand other perspectives. So at kind of a starting point, I think it's important to acknowledge that I'm not Native myself, and as a white woman working for a tribal organization, I recognize that I occupy kind of a delicate space, and that so one of my top priorities is approaching all of this work with a great deal of humility and recognizing that one of my highest priorities is to represent the perspectives of the tribes as authentically as I can, and so that's kind of the space that I'm coming from today as I'm here with you. And I really want to start with looking at why this is such an important topic, especially for American Indians and Alaska Natives, why we're here we're at this conference and why this is such a top priority. So the chart on the screen is looking at U.S. life expectancy over the past century. And you can see that there's been this tremendous increase in life expectancy for the general population, almost continuous growth. And then until this very end, the past few years, you see the COVID years, you see a drop there. And so that drop of 2.2 years for the American population was characterized as catastrophic by the public health community, right? And you can see why, because there's been this continual growth for almost 100 years. And then for the first time in so long, we've seen a drop. But then when you actually break it down into smaller groups and you're looking at subpopulations, you see that there's another story here, right? So 2.2 years lost life expectancy for the general population was catastrophic. I don't even know what language to use for the 6.6 year drop that American Indians and Alaska Natives experienced during that time, right? So you can see on this chart, the orange there, you see that American Indian and Alaska Natives not only started out behind, but lost much more ground during the COVID years. And so that's kind of to highlight why we need to be having this conversation. This is a really urgent moment. It is in a lot of ways a moment of crisis. But there are a few things that I want to highlight while we're on this slide, just starting out the presentation of here are the three main takeaways that I want you to take from what I'm saying today. The first is that this outcome is the result of policy choices. Right? This is the result of policy choices that have been made in the past. And so it's going to take intentional policy choices in order to move us forward into a different direction. The other piece is that in order to know what policy choices are the right steps to take, we need to be listening to different voices. And so we need to be making sure that the perspective that we're taking is including the voices of the people who are the most impacted. If you want to know how do you advance tribal health equity, the experts are going to be the tribes. And so that's our starting point. And so it's not only a moment of crisis, but it is also a moment of opportunity. We're seeing the federal government prioritize health equity in a way that it never has been before, right? The fact that we're at a health equity conference being hosted by the Centers for Medicare and Medicaid Services is monumental, right? This shows a substantial shift in the federal priorities and in how we're approaching these issues. And so this is an important moment where we're seeing progress and where if we take advantage of it, we can push things forward in a way that we haven't been able to in the past. And so as we've been watching all these different new health equity frameworks and equity action plans come out of the different federal agencies, we've been sharing them with the tribes and kind of getting different perspectives and feedback on kind of how things are going, right? So, and during that process, we've heard a lot of optimism about, these are a huge step forward, that the government is taking these steps, that it's making this a priority. But we've also heard a lot about there's sometimes a mismatch or misalignment in kind of the perspectives that are going on. And so while we recognize that these are really important frameworks, that health equity is in the center stage, there are pieces missing. And often the pieces that are missing are the pieces that from a tribal perspective are the most foundational. So as you're looking at these frameworks for health equity, like the CMS framework for health equity, right, lots of really important pieces in there. But there's no discussion in there about the impact of historical trauma and the need for healing from that. There's not a lot of discussion about accountability. There's not a discussion of the connection and importance of land and to people's health, or the fact that American Indians and Alaska Natives have a unique political status and unique relationship with the government of the United States, right? So there are all of these pieces that are really foundational to a tribal perspective of health equity that haven't really been encompassed in the discussions so far. And so that's where we really wanted to focus. And then recognizing that that piece was missing, CMS funded the National Indian Health Board to do a series of listening sessions and a health equity summit in order to try to fill that gap and to understand what a tribal perspective of health equity is, because that's going to be the starting point for how to know how to move forward. So we did this series of events in 2022. And we were focusing on these key questions, like trying to understand why are these health inequities happening? What are the key drivers behind them? Why have previous efforts not worked? We've been talking about health disparities for 30 some years now. So why are we still seeing a drop in life expectancy? And then what is unique about working towards health equity in Indian country? And in particular, what is the role that CMS can play? What are the levers that Medicare and Medicaid can pull that can make a difference in this space? And so one of our health equity summit participants really summed up the purpose of this whole project very well for us. When they said, how do we create the conditions for equity for Indigenous peoples? Equity for me is fundamentally about justice. So we might ask, what does a just system for health look like for Indigenous peoples? How do we create the conditions for just systems to thrive? Right. So that's really our purpose here, and what we're trying to achieve is to understand that answer to that question. And so we took all of the perspectives that were shared through all of these events and wrote a report looking at the key themes that came out of it and what a path forward can look like. And so as we were looking at what are the key drivers of health inequities, where do these all tie back to? We really found that when you trace all of the different pieces back, they really all come back to colonization. And that we saw that these colonization policies have these ongoing impacts, that they resulted in disconnection from community and from culture. They resulted in disruption and distrust, especially between different governments, between tribal governments and state and federal governments. We saw an erasure of Native peoples in the public consciousness, and in policy making venues especially. And we see these systemic and perpetuating barriers. So things like generational poverty and not having access to healthcare, not having access to education and jobs, right? And so those are kind of all the things that collectively have led to this disparity in the life expectancy and in all of these other health disparities that we've seen. But there's a couple of other things that I really want to point out from this slide, right? And so the first is that we're not talking about ancient history here. I know a lot of times when we talk about colonization, people tend to think, way back to the founding of the country, that kind of thing, right? Things started there, but has continued. So, for example, Native peoples didn't gain the right to freedom of religion until 1978, right? So we're talking about when, the charts were taught by queens, we are the champions, right? That's when you're gaining the right to freedom of religion, right? That's not a long time ago, right? And so in the 70s, that was when we saw policies of forced assimilation, like the federal boarding schools were going on into the 70s. Genocidal policies like forced sterilization were going on under federal government policy into the 1970s. So we're not talking about ancient history, we're talking about people's like aunties, their parents and grandparents, right? And then kind of the other piece of that is that colonization acts as a flywheel, right? So that it has so much momentum behind it, all of these policies that have been building for the past several hundred years, that even now that they don't require ill intent in order to keep them going. They have so much momentum behind them that they will continue to cause harm, and that legacy will be ongoing unless there is a very concerted effort to stop it, right? And so doing nothing isn't enough to stop the harm from continuing. So the other piece of it is that policy choices got us into this mess. Policy choices can get us out, right? So we can use policy effectively to move forward and to undo these harms and to build a different future if we're including the right voices and listening to the right perspectives of how to get out of here. So, so the next piece about why haven't previous federal efforts worked? Well, partly it's because those voices haven't been included in the conversation, right? And which results in culturally inappropriate interventions, things that don't make sense from a tribal perspective. A failure to recognize that U.S. policies were the root causes of those health inequities. If you don't understand where they came from, you don't acknowledge where they came from, you can't undo the harm, you can't move forward. Disregard of historical and ongoing trauma of American Indian, Alaska Native people, insufficient resources. As Dr. Carol mentioned, right, we've had 100 years of reports saying that congressional appropriations are catastrophically inadequate for addressing the needs or for even fulfilling the most basic promises that have been made, right? So we are talking about contractual obligations of the federal government that have been ignored. Paternalism instead of self-determination, and focuses on deficits and disparities instead of strengths, which I think is a really key piece that has been lost, right? So we have to balance out the recognition of the harms that have been caused and the problems that are ongoing with knowing that tribes do have the answers, that there are inherent strengths there, that if that's where we're focusing, we do have a path forward. And so what are some of the components of that path forward? We pulled out kind of 9 key themes of what that looks like. They're all in the report. I'm going to highlight only a few of them today as kind of the pieces that rose to the top as being both very high priority and immediately actionable. And so those were the recommendations that we pulled out to go into this, the tracker that Dr. Carol was describing, the CMS American Indian Alaska Native Health Equity Tracker. So the pieces that CMS is going to focus on in order to move forward, in order to start to undo some of the harm that's been caused in the past and to make sure that the future going forward, it looks a lot different. So one of the top things that has always come out is the importance of tribal sovereignty into this conversation, right? And so if policy choices from the U.S. government were the root causes of a lot of these problems, and the divesting of power from the tribes and the paternalism, then giving that power back to the tribes and respecting self-determination is going to be the path forward. And so this is a really important piece of understanding what tribal sovereignty means, that tribes have the right to govern their own people, and the understanding the nation-to-nation relationship that exists between the federal government and between tribal nations, and kind of understanding that means that American Indians and Alaska Natives have a unique political status and a unique relationship, that term, even American Indian Alaska Native, is not primarily used to describe a race. It's a political status. And so that means that you have an entire population that really needs to be treated on a different terms than other types of health equity conversations that are going on. And so that really feeds into one of the priorities that went into the tracker that Dr. Carol was describing around training for CMS employees, because this is one of the first roadblocks that we run into over and over again, is just this fundamental misunderstanding or lack of knowledge about even what tribal sovereignty means, that there is a government to government relationship, that what that political status, the consequences of that, and what the implications for policymaking. And so making sure that there's at least that fundamental knowledge of these really core concepts is going to be a really significant step that's necessary to achieve health equity and for CMS to be able to be a very strong ally. So another piece that a really important theme is disrupting structures of inequity and shifting the balance of power. And so one of the really important recommendations that came out of this theme is really the importance of tribal consultation. And that also made it onto the tracker. That's one of the ways that the federal government makes sure that tribal perspectives are taken into account in policymaking. It's one of the most important places where tribes have a voice in what's going to happen, that's how they can protect their sovereignty and make sure that choices that are being made are going to be helpful and not harmful. Because even very well-intended policies can have impacts that were not anticipated, that the federal agencies might not anticipate, because Indian country just functions so much differently and tribes have such a unique context. And so tribal consultation is one of the really key routes of making sure that tribes have a voice at the table, that they're able to say what the impacts are going to be for their people, and to make sure that there is a path forward that is beneficial for everybody. It's also legally required, even if it is often in practice neglected. So it's one of those areas that can be very effective. We already have the tools for it. There's already policy requiring it. So a commitment from CMS to enforce those policies is going to be a very effective step forward. Increasing visibility of American Indians and Alaska Natives, just making sure that visible in policies, visible in documents, visible in frameworks, but especially one of the most actionable is visible in data is one of the policy priorities. So that piece is also on the tracker of making sure that there's not just an asterisk there where it says American Indian, Alaska Native, right? That we actually have some kind of data to work off of, and that data can build in accountability. Honoring Indigenous knowledges. Right. So this kind of comes back to the idea of needing that perspective shift of recognizing that you might be an expert in healthcare or an expert in public health, but that doesn't make you an expert in tribal health equity. Right. So it's recognizing that having the humility to know that you don't know everything. And even from an agency perspective, recognizing that they need the perspectives of those other voices in order to move forward, and that those Indigenous knowledges have incredibly valuable strengths that are important to this conversation of health equity. And supporting tribal institutions, right? So a strong Indian healthcare system is necessary to achieving health equity for American Indians and Alaska Native people. And so part of that really ties into those, the TTAG administrative policy priorities that Dr. Carol was mentioning. Many of them have to do with reimbursement rates and making sure that enough resources are making it into the Indian healthcare system so that those medical institutions are strong enough to provide the care that's necessary for their people. And so that's why those tend to rise to the kind of the top of the priority list, are around making sure services are reimbursed and reimbursed at a rate that is sustainable. So those are some of the top policies recommendations that came out of it that CMS has committed to acting on. And then kind of following on that idea of a perspective shift of trying to understand health equity from an Indigenous perspective, I wanted to share this is another tool that NIHB has been involved in developing. And it's been adopted by the United Nations Permanent Forum on Indigenous Issues and the World Health Organization. And it's this framework of Indigenous determinants of health. And so it looks kind of beyond kind of our current discussions around social determinants of health and expands it into a more Indigenous perspective, understanding that there are really important pieces there that are missing from that conversation. So understanding the role of the health of Mother Earth, the having more intergenerational holistic healing perspective, and re-indigenizing culture are kind of like the main core themes. And then there's 33 different pieces that kind of fall under those. And so this is kind of an international perspective of Indigenous determinants of health. And then there's going to be some variation across different Indigenous peoples, but these are some common themes that have come out. And it's a way to help policymakers to kind of shift perspectives and understand a different way of looking at health and health equity, and understanding what those key drivers are and where to focus efforts moving forward. So really our key takeaway here is that health equity can't wait, but we also have tools and resources and strengths available to us to make meaningful progress, and we know how to move forward from here. And so this is really a story of hope, that those predictions of life expectancy are just predictions. We can make sure that those never come to fruition, that instead we can change all of the odds and make sure that the babies born today are not dying at age 65, but live long into the future if we're making different policy choices. And so here's my contact information, and there's a couple of QR codes there to the report on Indigenous determinants of health and to the NIHB Health Equity Report, if you so you can read those for more information. And then I will turn it over to Dr. Matsuoka.
Thank you so much, Carrie and Dr. Carol. As Dr. Carol mentioned, my name is Karen Matsuoka. I'm the Senior Policy Advisor for Health Equity and Medicaid and CHIP. And you've heard both Dr. Carol and Carrie talk about this importance of data, and especially data for measuring our progress and holding ourselves accountable. So that's what I'm hoping to share a little bit with you today, is how we're improving and using, in particular, demographic data to measure disparities, and then how we're leveraging that data infrastructure to develop a way to monitor key indicators of tribal health and health equity, this tracker that both Dr. Carol and Carrie have been mentioning. So first, just a little context about the intersection of Medicaid and CHIP and the tribal community. Medicaid and CHIP are an incredibly important source of health coverage for American Indians and Alaska Natives. As this slide shows, 1 out of every 3 American Indian Alaska Native individuals were enrolled in Medicaid and CHIP in 2020. So a third. And yet, while for this reason, Medicaid and CHIP are important drivers of health access through coverage, we also know that persistent disparities for this population persist within Medicaid and CHIP. So you see some of those here. So American Indian Alaska Native women in Medicaid and CHIP are 3 to 4 times more likely than their white counterparts to die from pregnancy-related complications and more likely to have a preventable death. And you've heard from an earlier conversation today that, an estimate of like 80% of those deaths are preventable. Compared to white beneficiaries, American Indian Alaska Native beneficiaries also report worse experiences when it comes to their health care, whether that's about getting care when they need it, getting care quickly, how the doctors that they interact with communicate with them, as well as the kind of customer service that they might get from whatever health plan that they might be enrolled in. So for us in CMCS, we see this as not only an important opportunity, but more importantly, I would say a moral imperative for us to do something about. And as Carrie mentioned, this topic of health equity has been a priority for us, like it's never been, at least in the 8 years that I've been at CMCS. And I want to assure you that within this administration, within CMS, that commitment to health equity also permeates the entire organization. And what you see here is just a quick excerpt from a health affairs blog that appeared in 2021 that was co-authored by our CMS administrator, Chiquita Brooks-LaShore, and the CMCS director, Dan Tsai. And here, what they're talking about is the directive that they've clearly given to us in CMCS to really take a look at this data. Because what we don't know, what we can't measure, we cannot fix. We can't measure progress without a baseline. And so one of our key priorities has been throughout the now almost 4 years that I've held this position, which was also created as a sort of testament to how important health equity is to this administration. We've been charged with doing a lot of hard work to improve the accuracy of our data, the consistency and completeness of our data, so that we can start to look at our data and really understand where we're falling short and hold ourselves accountable for making progress. So despite all the hard work, progress really hasn't been as quick as we would certainly like, but progress is there. If any of you were here last year, you might remember this slide. This was literally the first time in the history of Medicaid and CHIP. It's a little bit embarrassing to say, but for the first time in the history of our programs, that we were able to say something meaningful about the composition of our beneficiary population. So what you're seeing here is some demographic data about the racial and ethnic composition of our Medicaid and CHIP population. This was in 2020. And so we saw, for example, that approximately 1.3% of our population identifies American Indian and Alaska Native. That comes out to something around 1.25 million individuals. We also learned, and we're not surprised, but we learned that our population is also more racially and ethnically diverse than the overall U.S. population. So that was a momentous step forward just in the basic data infrastructure we have to do some of the demographic data analysis that Dr. Carol talked about has been missing and called out as missing in so many prior reports. But this year, we're proud to show the next big step that we're able to make now that we have that demographic data, which is to use that demographic data to now start getting a picture about how well we're doing for our tribal community. So we can take, for example, maternal health, which is a priority area of focus for us in Medicaid and CHIP, because Medicaid and CHIP together cover over 40% of births in this country. And in some states, that percentage goes up to 70%. So what you're seeing here is 2021 data, which is the most recent data that we have. And you'll see that 3.4 million beneficiaries were pregnant at some point in that year. And of that number, 46,000 roughly identified as American Indian Alaska Native, And of those who had a delivery in 2021, you'll see that severe maternal morbidity rates were 380 per 10,000 deliveries for the Medicaid and CHIP population overall. But for the rate for the American Indian Alaska Native population was higher at 439 per 10,000 deliveries. And because this is inherently a measure of a worse outcome, for this particular measure, the lower the numbers you have, the better. And so clearly there's a lot of room here for us to do work for us to do to narrow the gap. You heard Dr. Carol also mention that diabetes is another area of focus because prevalence is very high in our tribal communities. So here you'll see just two of the indicators that we've begun tracking for diabetes. Since diabetes can generally be well controlled in an outpatient setting, an important outcome measure that we track is the rate in which individuals with diabetes have to be hospitalized for short-term complications, because that to us is a critical indicator that whatever the access to care in the outpatient setting might have been, or whatever the quality of care should be in the community setting, it clearly wasn't sufficient because what you're seeing is an avoidable hospitalization. So here as well, lower numbers are better. And you'll see that in 2020, for the overall Medicaid and CHIP population, the rate of hospital admissions for short-term diabetes complications was 17.3. However, the rate for the American Indian Alaska Native population was almost 2 times higher at 27.8. To help us figure out and make this data actionable, in addition to looking at these outcome data and the disparities there, we're also tracking important process measures to help us see where we can improve to drive improvement on those outcomes. So that's why we look at things like receipt of an A1C test. Most clinical guidelines, if you have type 2 diabetes, recommend that you receive an A1C test 2, if not 4 times a year. And so one of the measures that we track is of the individuals who have Medicaid and CHIP coverage who have diabetes, how many received at least one A1C test in the prior year? Here, higher numbers are better. So you'll see that 80% of Medicaid and CHIP beneficiaries overall who had diabetes received at least one A1C test in 2021. But compare that to only 53% of our American Indian Alaska Native beneficiaries who got at least one A1C test in the prior year. Dr. Carol also mentioned children's health. Again, another huge area of focus for us just in general on Medicaid and CHIP, because over half of our population are children. And I read an estimate recently that something like almost 2/3 of children, over half of children in the country rely on Medicaid or CHIP as their primary source of coverage. So child health is another area of focus for us. So this slide shows just two of the indicators that we're tracking for children's health. On the left, you'll see that roughly half of all children enrolled in Medicaid and CHIP received at least one child visit in 2021. However, only 34% of our American Indian Alaska Native children received at least one well child visit. And these well child visits are incredibly important. These are the visits where the provider's tracking milestones, where recommended immunizations are provided, things of that nature. So the fact that, so few had even one well child visit, is troubling. And what you'll see on the right is an important screener for prevention that we look at, as well as for social determinants of health. For Medicaid beneficiaries, all beneficiaries between the ages of 1 and 2 should be screened for lead poisoning at least once. That is a Medicaid rule, actually. And so you'll see that for our children overall, only 28% overall received even one blood lead screening test in 2021, but that number is even smaller for our American Indian Alaska Native children at 15.7%. So these graphs tell us not only is there just an incredible need for improvement for children just overall, but especially so when it comes to our children from tribal communities. Then finally, a couple indicators of oral health. States are required, just by way of context, to provide comprehensive dental benefits to children covered by Medicaid and CHIP. And we also know, just like with diabetes, that if you have adequate access to good, high-quality oral health care in the community, you shouldn't have to go to the ER for a dental issue like tooth pain. And so one of the key measures of outcome and access and quality care that we look at are what is the rate at which an individual with Medicaid or CHIP coverage is showing up to the ER for some kind of oral health issue. So here again, lower numbers are better. And you'll see that in 2021, the rate of dental ER visits per 100,000 beneficiaries among children with Medicaid and CHIP overall was 356, but that rate was higher for American Indian Alaska Native children at 444. So this graph also not only shows the disparity, but also that coverage alone is not enough to ensure adequate access to high quality oral health care in the community. However, stratifying by age, in addition to race and ethnicity, presents an even more nuanced picture to understand what might be going on behind these numbers. So what you're seeing here on the left, on your left, my right, is the very same information from the prior slide, but scaled to mirror the axes for the corresponding graph for adults aged 21 to 64 with Medicaid coverage and their rates of ER visits for dental issues. And here again, for context, as I mentioned, states are required to provide comprehensive dental benefits for all children enrolled in Medicaid and CHIP. That's not the case when it comes to adults. States have discretion as to whether they offer any kind of dental coverage at all. And while most states now currently cover at least some kind of emergency level set of benefits, roughly only half of states offer comprehensive benefits, dental benefits, when it comes to adults. And of course, we have to use caution whenever we're looking at correlations and not infer causation. But these graphs do suggest that coverage can make a huge difference. Maybe it's not sufficient from what we know from the children's context to ensure good access to care, high quality care. But what you're seeing on the right for the adults suggests that coverage does in fact play an important role, because what you'll see is that the rates of avoidable ER visits for adults is over 4 times greater than that for children. So hopefully these slides have given you just a glimpse of how we have prioritized data, improving that data so that we can start holding ourselves accountable and really starting to understand, where we're starting from so that we know exactly how much work we have to do and where we have to go. With this data, we now have greater insight into not only our overall performance on key indicators of health, but importantly for equity, we understand where the disparities are, what their magnitude is, and what some of the drivers might be that we might be able to pull, to Carrie's point, to close the equity gap. Our ability to stratify data like this represents, like a huge leap forward. It might seem like a small thing, but it's a huge leap forward in just what we're able to do with our data. And ultimately, what I wanted to leave you with is that absolutely, the goal was not ever the collection or the assessment of data for the sake of data, but to actually do something with it, to Carrie's point. So what you see here from that same blog post that I mentioned earlier, our leaders talked about sort of a 3-prong approach to how we think about health equity and Medicaid on CHIP. Measuring disparities, for all the reasons that I've talked about, is just the first step. So measuring disparities is our starting point, but it's not the end point. Because what we need to do now is, now that we know where the disparities are, we now need to take the second step, which is to encourage our state partners to adopt the things that are innovative, that are evidence-based, that are requested and demanded from our tribal partners who, to Carrie's point, know exactly what they need to close the gap, and encourage and work with our state partners to start adopting those and paying for those so that we can, over time, achieve the dream for health equity for our tribal community. So here's my contact information for anyone who might have additional questions. And with that, I think I'm going to turn it back over to Dr. Karol. Mm-hmm.
So that's our journey so far. It isn't done. It certainly won't be done in the near future, but we'll continue to look at this information over the next year on an annual basis. We hope to continue to move a lot of this information forward. Our tracker that we have is a living document, if you will, and will include additional TTAG priorities, additional health report recommendations, and looking at the Centers for Medicaid and CHIP Services metrics to move additional metrics into the tracker to help show that although small, we hope that we will see some improvement in health equity for American Indians and Alaska Natives. So we'll stop here and see if anybody has any questions for us in the little time we have left. Yes.
Dr. Lyons, American Occupational Therapy Association. I'll repeat it. Dr. Lyons, American Occupational Therapy Association. Thank you so much for this. This is, it's melting my heart to hear that work is happening, even though we have leaps and bounds to go. My question is kind of two-part in regards to policy. You had mentioned the policies are there, and I know we can't always equate, causation with correlation, but I'm just curious of why do we think those policies that are there aren't working, they aren't being utilized? And then what efforts are there currently for increasing the community health workers, those who are part of the tribal communities, to actually be employed and work with CMS to make some changes?
That brings about 5 different questions or 5 concepts that we have been working on, that we're thinking about, that we're looking at. I have to thank the Indian Health Board, the National Indian Health Board, for getting out into the communities to talk with everyone about it, for bringing those comments in. We'll continue to look at the policies, identify where the issues are. It's part of the social determinants of health. We just don't have the funding. We don't have the education, and all the different structural pieces that we need. We at CMS have been trying to look at where are those American Indians, Alaska Natives that might come to CMS. We've been trying for about 3 years now. And the 0.5% of American Indians that are employed by CMS remains pretty stable. But we don't have it increasing. That number isn't like the Indian Health Service that might have tribal preference to bring those individuals in to help with the issues that we see. Dr. Karol continues to pound on the table and say, don't forget, tribal. People are kind of smiling when they see Dr. Karol coming, because that's my focus is to work from the Indian Health Service, where I knew where the different difficulties were, come to CMS, try to help us include CMS in everything that gets done, because they're part of tribal healthcare. Whether they appreciate it or not is still being developed, but it has been an important part to help the Indian Health Service get American Indians, Alaska Natives enrolled, get them to seek healthcare, provide that reimbursement to sites, to build better facilities, get more equipment, get the staff. And it's starting to roll, but it definitely is a big push uphill. I don't know if any of you two want to add something.
I could add just a little bit onto that. So especially the consultation policy, right, was the one where I said, like, this policy already exists, that federal agencies are already required to conduct tribal consultation on any policy that could have an impact on tribes, on tribal members, or on tribal lands. But it really is going to take a culture shift within the bureaucracies of these agencies in order for that policy to really be implemented. It's going to take some accountability. Part of the problem is that those policies don't have any teeth to them. There's no consequences for not fulfilling the policy. And then there's also the issue of just the people that should be carrying out these policies don't really know them or understand them. And so you really have to kind of address all 3 of those pieces in order for the policies that do exist to be effective.
And the only thing I'll add is that, the numbers that I showed, hopefully people can still hear, but the numbers that I showed are national numbers. And what we haven't shown you yet are what the different slices of the data look like if we add in even more stratification. So when we start to look at this information, let's say at the state level, because especially in Medicaid and CHIP, there's a lot of flexibility in terms of how states administer the program. And so one of the things that we're starting to look at is, what do these numbers look like at the state level? And as you might imagine, there's just as much variation in these outcomes when you look at it state by state, as if you looked at it by race ethnicities, if you looked at it by rural, urban, if you looked at it by disability, or, people who aren't disabled. So by starting to look at where good things are already happening and where the outcomes are strong, and just really start to kind of peel back the layers of what's working here and what might be able to kind of lift out from one state that's doing really well and kind of share the secret sauce, if you will, with other states. I think it's going to be part of the solution of figuring out what might already be working. Where is tribal consultation already strong? Where is traditional healing already being reimbursed for? To look at these drivers and start to magnify that and make sure that it's more the norm and not the exception.
Hey, Dave Merrill, GDIT. Thank you, by the way, for all the effort that you've put into collecting the data, presenting the data, all those listening sessions. That's a lot of work for sure. And as I listened to you, it became clear that this is a very complex challenge. I mean, when you talk about states and Medicaid, and they're all different. We've got different tribal nations in each of these states. What do you see as some of the low-hanging fruit, the easy things to start to pluck away at some of those very complex policy issues, things that we could, as a community, start to work toward at that might make an impact, but are low-hanging fruit items? If you don't mind commenting on that.
I'd be happy to. So as part of the tracker, we have, we know what is low hanging fruit, and we're plugging that into this first round of the tracker so we can show benefits, show improvement, and therefore allow us to tell everyone the good things that we're doing rather than hiding the tracker saying, oh, we're not there yet, or we didn't do this, or we didn't do that. So what we mentioned today are low hanging fruit, are policy things that we think we can change. So that's where we're getting started. Who's next? Over here.
Thank you for this discussion. My name is Sunini Odell. I'm a nephrologist, and I was just wondering, we don't hear a lot about kidney disease, but we do know that there's a high risk of kidney disease in our populations and communities. And we have the risk factors. You showed data on diabetes and lead, which is a risk factor even for kids to develop kidney disease later. But it is a community, like you said, that we really have to do a lot of homework before we really begin to understand the underlying problems and how to really address it. But we're very interested in it. Danelle and I work on, we're the health equity team for the Vida Kidney Care. And we've been thinking about other populations that we really need to talk about. And the American Indian population is high on our priority list. And we're just wondering, is there any work being done in that area already? And how can we work?
Yes, there is a lot of work being done. One of the great data pieces that the Indian Health Service shared a few years back was how kidney disease has plummeted in the American Indian Alaska Native population, which they attribute to their special diabetes programs for Indian. I can connect you with the Indian Health Service, let you work with them to show what they think is happening and why it's getting better, which is one of the big pluses for Indian healthcare.
The Special Diabetes Program for Indians is one of the most successful public health programs ever to exist in the United States. Unfortunately, it remains chronically underfunded and is constantly on the chopping block. And so that's one of our big priorities, is just to make sure that it continues to be reauthorized and that hopefully to increase the appropriations level, because we know it can make such a substantial difference. If it was fully funded, it could go a very long way to addressing a lot of the chronic disease that we see across tribal communities.
Yes, sir.
I think you have a microphone.
Oh, sorry. Go ahead.
Yeah. Thank you. This is incredible. I've always knew that the social determinant of the wheel for Native Indigenous populations should be complicated. So when I saw that wheel, thank you for that hard work. Most of us here that represents the industry could help this population, like today, yesterday. But it always goes back to, we don't have enough funding. We don't have enough funding. It's too complicated. The low-hanging fruit, I love that question. I have an answer for you later. But innovation starts with thought and process. You guys are government. we need a contract to help you. Have anyone thought of that the contract itself is the problem? Not the budget, but the contract. It is not long enough to sustain a solution. But you guys get guaranteed funding, right? IHS gets guaranteed funding, CMS gets guaranteed funding. If we could give you the solution today and benchmark an acquisition mechanism called the public-private partnership to have a long, sustainable approach to give you the solution versus waiting for a contract, waiting for the budget. Have you guys ever thought about that?
No. But I will say, CMS is not 100% not looking at it. You probably heard about the 12th scope of work.
Yeah.
The 13th is coming out, which will include a giant American Indian Alaska Native pillar of quality work that will need to be filled. So if you keep your eye on some of the stuff that comes out from CMS, probably closer to August, there's a big opportunity to contract and to start some of that work, as I think CMS is identifying, as I keep saying, the lowest, the worst, the morbidities, the mortalities to continue to be terrible, and we need that support. And I think they're listening. So.
Yeah, because I always go back to the DoD, right? The DoD, if they have a new weapon system, they need a new hangar, right, for a plane. Well, they don't have the money to build 1,000 hangars. But guess what? A company could come in and build those hangars, but they have a 30-year contract, right? So I think it needs to be, the mechanism needs to be looked at to see if we can improve the contractual mechanism so we can help you today versus waiting. So thank you.
Thank you.
I would add a little bit onto that. I guess partly just clarification, the National Indian Health Board is not a government agency, right? So we were established by the tribes and represent the tribal voice. And I think that that's a really important piece. I think there is a role for private industry to play, but that's not where the answers are going to come from. The answers have to come from the tribes.
Oh, 100%.
Right. So.
100%.
Okay.
But I do think the point of having a longer view of health and investing in health is a higher priority. I think that point is well taken.
Okay. I want to go over to that gentleman over there, and I'll come back to you next.
Hi, I'm with the CMS Navigator program in Oklahoma. And so wanted to get some ideas from the group on how well marketplace plans are working. In Oklahoma, we're proud that we have over 30,000 tribal members in marketplace plans, which puts the proportion at just about the same proportion as the population tribal in Oklahoma. So we're seeing good success with marketplace plans to expand coverage. From your folks' perspectives, how marketplace working?
Marketplace will roll back to the unwinding program that we're going through right now, which has stumbled a little bit in American Indian, Alaska Native re-enrollments and eligibility issues. But definitely as individuals fall off of COVID levels, we're pushing towards the marketplace. So there's an uptick. As you said, different states have different successes and others are very limited. So it's not across the board, but there is improvement in the marketplace enrollment that we're seeing, modest, but happening.
Yeah, I don't know. I can talk loud. My name is Carrie Howard, and I work for Stratus Health. And most of my work is on a CMS contract that falls under Task Order 4 through the QuickUIO program that we call the Partnership to Advance Tribal Health. And I am also a NRHA Rural Health Fellow this year. And so my question is, how do we get some of these other organizations and these partnerships to do some of that advocacy and education to people like the rest of this room on a much broader scale?
I'll give you guys a show. I'm a little stumped. I'm not quite sure how to get there. I'm hopeful that the 13th scope of work, which will raise it from just the Indian Health Service side, over to full tribal communities, which will include IHS, tribes, and urbans, to look at improving their quality of healthcare. So that's potentially one way that it might open it up more across the healthcare, the American Indian Alaska Native healthcare system in the future.
And to for the purchase referred care system, it really is in private sector's best interest to lobby for that funding because they are often the purchase referred care providers.
Correct. And with the increasing enrollment in Medicare and Medicaid, the PRC dollars are going farther.
Yes. Yeah.
And that's been a great positive point in the different tribal communities.
I think you raised a really good point that that's an important piece. It's just having more people talking about it and educating within their sphere of control and sphere of influence. Because right, like that invisibility is such a key part of what's perpetuating the health inequities. And so bringing more visibility, just making sure that tribes are always part of the conversation is such an important piece. There's just so often that half of my job is just reviewing policies or discussions and just writing, what about the tribes, right? Like it's looking at legislation that says, states, territories, and locals, and then just putting a little caret and tribes, right? Like that's so much of my job. And so at the last meeting of the Secretary's Tribal Advisory Committee, one of the tribal leaders said he keeps on his desk a mug that says, what about the tribes, right? And puts it in every Zoom call, right? Like that's like the first thing. And I think that's something that anybody can be doing, right? Whatever conversations you're in. And we've seen that even make an impact. So one of the centers at CDC that we've been working with, the reason that they even have a tribal project within that center is that one of their leads on that project was well, we're in the center. Our center says that it serves, states, tribals, locals, and territories. We don't have a line item for the tribes. And she was I wasn't trying to be revolutionary. I was being pedantic, right? But, that just, it was in the name, and we didn't have a portfolio for that. And so she just started asking the question, what about the tribes, right? And now we have funding going. That's for electronic case reporting, right? That now tribes are part of that system that never were before. And so a lot of it really is just asking that question in whatever space that you're in. It can make a serious difference.
And with that, we're going to close. We've run out of time. Thank you for joining us today.